Hi everyone, I'm Amy Hemmington. So the good news with this presentation is that people with mental health issues receive just as timely cancer treatment as people without. But as you'll see from this presentation, there's still some way to go. So today I'm presenting a project that was conducted by the Cancer Support Team, When Mental Illness and Cancer Collide. So people with mental health concerns have the same rate of cancer diagnosis as the general population, but they fare more poorly in terms of outcomes. They're more likely to be hospitalised, and they have a 30% higher rate of mortality. So why is this? Do MH patients present later and therefore have more advanced cancer? Are they more clinically complex? Research shows that people with mental health issues tend to have more comorbidities. And we know that this leads generally to poorer health, but it can also interact and interfere with cancer treatment. And then on top of that, they're more likely to take psychotropic medications, and this can also interfere with treatment due to drug interactions. Are they less likely to receive treatment, whether that's due to their clinical complexities or due to discrimination? Do these patients live in greater deprivation and therefore have greater barriers getting to treatment and adhering to treatment? Or are there features of mental illness itself that affect these patients' ability to be able to make decisions about their treatment, as well as things like risky health behaviours? A recent national level study that was conducted in New Zealand by Cunningham looked into this a little bit. They found that mortality was significantly higher for cancer patients who had a diagnosis of serious mental illness. And they defined serious mental illness as schizophrenia, schizoaffective disorder, bipolar, and other affective psychoses. And they found that both later stage at presentation and also comorbidities contributed to this survival difference. Am I quite loud? Louder than I thought. We wanted to broaden this investigation to beyond just patients with serious mental illness, to look at people with all types of mental health concerns. And we also wanted to know whether these disparities exist within counties Manukau as well. So the aims of the current project were to determine whether counties Manukau cancer patients with mental health issues do fare more poorly, and what factors might be associated with this, and then to disseminate our research findings and look at some interventions for improving these disparities. So we began by collecting a list of patients on the 31-day faster cancer treatment pathway. So this is an initiative from the Ministry of Health, which requires patients to move from decision to treat through to their first treatment within 31 days. So the patients on this list all had a date of decision to treat between the 1st of January 2016 and the 31st of December 2016. So we looked at patients from that 1 year period. We then cross-referenced that list of patients with HCC, which is the mental health database, and we also cross-referenced it with community dispensing, which is prescription medications that are dispensed for patients. And this left us with two groups. So we had the non-mental health group, which were cancer patients who had not had mental health contact or been prescribed or dispensed a psychotropic medication in the last 5 years, and the mental health group, who were cancer patients who had either had contact with mental health services or been dispensed a psychotropic medication in the last 5 years, or both. There was some crossover. There were 31 cases that were excluded, and that was because they were either duplicate patients that had more than one primary cancer, or because they had a diagnosis of dementia or other organic psychoses. So we followed these patients for 1 year, up until the end of 2017. And our outcomes were delays commencing treatment, so breach of that FCT pathway, hospital admissions, 1 year mortality, and then the analyses that we used were t-tests, Pearson chi-squared, and logistic regressions. So our results. In terms of demographic variables, the MH group were made up of more female and European patients, and they were on average older. There was no difference between the MH and the non-MH group in terms of deprivation. The MH group did have significantly more comorbidities compared to the non-MH group, but there was no difference between the two groups in terms of cancer stage. Next, we looked at the differences between the groups in terms of our outcomes, which is this ugly table up here. These are just top-line analyses, so we don't take into account possible confounds at this stage. But what we found was there was a marginal difference between the two groups in terms of mortality, and this was p.073. So there was a higher rate of mortality in the MH group, and we expect that this would probably reach significance if we had more power in the study. There was no difference in terms of SCT breaches, so no differences in delays of treatment, but there was a significant difference between the two groups in terms of hospitalizations, so the MH group was significantly more likely to be hospitalized. We then focused more closely on the outcome of mortality, and we used regression analyses entering all of our variables into one model to see which of the variables might be explaining or might be able to explain the differences between the two groups. So across the sample as a whole, cancer patients who were older, Maori, other ethnicity, had advanced cancer or high comorbidity score, then they had a higher rate of mortality. But there were no differences in terms of deprivation, psychotropic medication, or mental health contact when it came to the outcome of mortality. And we think this suggests that the marginal differences seen in mortality between the MH and the non-MH group are explained by other factors than their mental health status. We did the same for hospitalizations. We found that across the sample as a whole, cancer patients who were younger, had more advanced cancer and a higher or more comorbidities were more likely to be hospitalized. Cancer patients who were taking psychotropic medication were also nearly 2 times more likely to be hospitalized. And there was also a marginal difference such that people or cancer patients who had had contact with mental health services in the past 5 years were half as likely to be hospitalized, so less likely. So what this research has told us, mental health patients at Counties Manukau are just as likely to receive timely cancer treatment. But in the first 12 months, these patients are also more likely to be hospitalized and they're marginally more likely to die. And what are the possible reasons for this? Well, this research has shown that patients with mental health issues and cancer are more likely to have more comorbidities. And it's also shown that having more comorbidities is related to a greater likelihood of being hospitalized and also a higher rate of mortality. MH patients by default are also more likely to take psychotropic medication, and this research has shown that taking psychotropic medication means cancer patients are more likely to be hospitalized too. However, from this research there is no evidence that MH patients present with more advanced cancer, though having cancer or advanced cancer was associated with a higher rate of mortality and greater likelihood of being hospitalized. And finally, there appear to be no differences between the two groups in terms of deprivation, and also there were no differences in the outcomes of mortality and hospitalizations according to deprivation either. So I guess in summary, in terms of preliminary evidence, this research has shown that maybe actually it's greater clinical complexities that are one of the factors that are leading to poor outcomes for MH patients in terms of cancer, both in terms of psychotropic medications and their higher number or more serious comorbidities. Whereas stage of cancer and deprivation appear possibly not to be factors in this research. In terms of implications, it's really positive to know that MH patients receive just as timely treatment when it comes to cancer, but this research doesn't tell us what type of treatment they had or how much compared to non-MH patients. And it also doesn't tell us how adherent they were to their treatment either. And there are still disparities for this group, so they're still more likely to be hospitalized and marginally more likely to die. And we think the first step to addressing these inequalities is awareness. So cancer clinicians need to be aware that this group are more vulnerable to poor outcomes when it comes to cancer treatment, and that they may need particular care when it comes to navigating that pathway and navigating their cancer treatment. And knowing that comorbidities and psychotropic medication play a role in this as well, does there need to be more consideration of this when clinicians are prescribing cancer treatment? And if we think this is the case, then in order to facilitate it, potentially cancer clinicians actually need more education and more support in this area. And then I guess the last thing is, what else could we be doing as an organisation to help support these patients more? Maybe there's a role for the cancer nurse coordinators to be able to support these patients medically more. And as clinicians, we wonder what you guys think, whether you think we could be doing more and what you think we could be doing. And we'd love to hear from you. I've actually included our email at the end of the presentation, so if you have any thoughts, we would love to hear them. These are just my references. And then I obviously want to acknowledge all the wonderful people that have been involved in this project. So the Cancer Support Team, Anne-Marie Wilkins, who was our wonderfully supportive service manager, Kristen for all of her statistics support, Nathan Considine for his support with conducting and planning the study, and then also Daisy, who was our summer student from the University of Auckland, and she spent many hours at a computer collecting data for us. Are there any questions?